In this second lecture for Unit 3, we're going to build upon the last lecture in which the focus was on financial administrative data, how to improve the revenue cycle to improve revenue overall, and how current HIPAA transactions and code sets may change or not for value-based care. Improving revenue cycle and revenue generation is not only important for revenue assurance in a fee-for-service environment, which still needs attention, but enables building a cushion upon which greater risk can be assumed. It is vital not only to balance the potential downside risks that can occur in value-based care, but to support revenue growth in general. Hospital inpatient revenue is decreasing as many more procedures can be performed in an outpatient environment. This change has been occurring over a fairly significant period of time, but is accelerating. As one of the latest examples, Medicare is now covering outpatient knee surgery, though not yet hips. Most commercial plans pay for both if patients are appropriate candidates for such. Outpatient surgery costs and risks of hospital-acquired infection are lower, and more movement around the home contributes to faster recovery. Outpatient and physician office visits are also seeing reductions as mobile health devices such as 24-hour post-chemotherapy injections and weight and blood pressure monitoring after a cardiac event are replacing the need to see a clinician in person. As we previously discussed revenue cycle improvement and changes in the healthcare landscape, we couldn't help but discuss the clinical environment in which those improvements and changes are taking place. We described the importance of clinical documentation to support appropriate coding of diagnosis and procedures for billing purposes. Accurate and complete medical coding can also improve data documented in an EHR for use in quality measurement. In this lecture, we're going to address the convergence of financial, administrative, and clinical data from the perspectives of the various stakeholders. First, we're going to look more specifically at the key reasons convergence of financial, administrative, and clinical data is so important for providers, health plans, employers, and the nation at large. Then we'll look at cost accounting as the key element on the financial administrative side that is needed for successful convergence. We'll look at the role of information technology and health information informatics management in the integration of financial, administrative, and clinical data within and across provider settings. We'll discuss the roles health plans and employers are playing in addressing cost reduction and improvement of quality of care, and the critical need for greater data sharing and transparency. Finally, patients play a role in convergence of data that not only includes pure financial, administrative, and clinical data, but in providing patient-reported outcomes that are important to them and lend a richer understanding of outcomes that can help all stakeholders consider outcomes relative to costs. In taking a closer look at why financial, administrative, and clinical data should converge, perhaps the most important reason we should consider, though least used at the current time, is to provide physicians understanding of the cost and efficacy of a treatment or procedure being contemplated to enable selection of what will achieve best outcomes. This not only requires information about cost and certainly clinical evidence from research, but an electronic health record that can supply this information to the physician at the point of care, as well as physician engagement and trust in the entire process of providing such information. Other needs for data convergence, however, are rapidly emerging. One is to identify variations in provider practice and disparities in treatment outcomes to optimize treatment, reduce errors, remove waste, and improve health. Certainly, health plans are starting to do this, and large, savvy integrated delivery systems are creating data warehouses to help them identify such variation as well. Since this could potentially be an enormous undertaking, analytics can also help identify a core set of metrics that represent critical aspects of quality on which to focus. For example, later in this lecture, we'll identify that there are 20 conditions considered most expensive by health plans. Individual provider entities may also identify their own top expensive conditions on which to focus at the local level. There are also significant business reasons for data convergence, such as to define episodes of care for bundled payment and fair capitation rates. Providers need to decide whether they should accept bundled payments from health plans when negotiating contracts, and both sides need data to make an informed decision. Within a given provider setting, data convergence provides information useful for evaluating service offerings and conducting other profitability studies. For example, should a hospital consider building or acquiring a center of excellence? As suggested by this discussion, supporting transparency in all areas of decision making regarding cost, quality, risks, and consequences is essential for value-based care. Some more specific examples of what we discussed generically in the last discussion include health plans starting to require pharmaceutical manufacturers to take on some of the outcomes-based risk, for example, by holding them accountable for medication adherence to reduce readmissions. Prices for pharmaceuticals have skyrocketed. In response, large health plans are also attempting to clamp down on these costs and have been somewhat successful in getting these pharmas to start lowering their prices. Prices of drugs are of particular concern to patients, as many drug benefits require fairly large co-pays. Employers contracting with health plans or directly with providers have started to be more direct in focusing on a narrow network of top performing in quality and cost providers and those who will also refer to such providers. Providers are beginning to look at reducing excessive, unnecessary, obsolete, and unreliable testing and procedures through automated clinical decision support at the point of care. Health plans likewise have started removing such tests and procedures from their coverage. This is necessary not only to reduce cost, but to reduce radiation exposure, waste, and as suggested by one physician, overdiagnosis, wherein, for example, identification and treatment of microcarcinomas could actually be a case for the treatment being worse for the patient than the actual condition. Providers with plan encouragement are enhancing use of evidence-based interventions to reduce unnecessary use and proactive management of opioids to reduce costs of other medication requirements, as well as reducing the direct costs of treating patients with such addiction and reducing the increasing surge of deaths from opioids currently being seen. Gaining consensus among physicians for improvement efforts is directly aided by financial, administrative, and clinical data convergence. Examples include the ability to better identify and adopt best practices, implement improved care processes, especially care coordination and throughput on test results, and develop standardized metrics that routinely capture and provide feedback directly to physicians on process and outcomes measurements. It should be observed here that physician buy-in is absolutely critical to any effort to change practices where cost cutting is the goal. Patients are also being urged to take part in reducing waste and unnecessary procedures. Choosing wisely is supplied by a foundation established by the American Board of Internal Medicine, so its roots are in the physician community. The website www.choosingwisely.org supplies information and encouragement for patients to engage in their personal health and health care by sharing in their health care decision making with providers. Interestingly, the site states that information supplied should not be used to establish health insurance coverage decisions. Interesting. Health plans, spurred by the American Medical Association, are also creating chronic disease funding programs for direct care support for the underinsured and for education programs in communities for prevention programs. This is certainly a recognition of the importance of social determinants of health. The examples we've discussed are certainly all worthy of the effort to bring financial, administrative, and clinical data together. Another way to emphasize the need for such data convergence is to look at some questions that would greatly benefit from data convergence for their answers. How can we increase claim reimbursement revenue and better manage debt and collection risk and provide equitable care at the same time? There are many facets to this question, all of which would be improved with financial clinical data integration. For example, identifying procedures that are likely not to be covered under an insurance plan reduces debt. Another question, can we better manage inventory and rein in supply spending? Hospitals in particular must maintain a large inventory of supplies, pharmaceuticals, etc. Systems do exist within departments to help manage supplies, and supply chain systems across entities do exist, but coordinating these with patient load can pinpoint areas needing attention as the population and their needs change. Should we take on more full-risk capitation contracts? Increasingly, health plans are pushing providers to take on more risk. Essentially, maintaining a large volume of providers on fee-for-service is not reaching value-based care goals for either providers or plans. How does a provider know if this is right for them? They need to study very carefully their costs, market share, provider referrals, and many other data elements to answer this accurately, and are frequently surprised with positive responses. Another question is, should we decrease our prices? Now, this may seem like a question that should always be answered no, but in fact, a change in pricing up or down could significantly improve volume. Once again, though, how many patients are likely to have conditions for which this would be a true deal breaker? Should we grow a risky service, that is, increase market share, where volume is potentially high but margins are low? Usually the answer to this is also no. However, there may be pressure, especially on a hospital in a small community, to do just this, and good data can help make the decision more accurately and easier to explain if the answer is negative. Should we increase physician and/or staff salaries or incentives? Of course, many would say yes automatically to this question, but hospitals can get in trouble with anti-kickback and Stark laws if they are paying physicians more than the norm. And there could also be issues with other staff, unions, and so forth, for all of which better data would help provide answers. Lastly, type 2 diabetes accounts for $174 billion in healthcare costs per year. It is 85% preventable through dieting, weight control, exercise, and regular medical checkups. So, should we target more primary care providers or endocrinologists? Should we close some beds and expand outpatient services? These are questions that might help us consider how we can take a part in lowering the amount of diabetics we have and the cost of their care. Other questions, should we acquire a retail clinic chain? Can we take on telehealth services? These are all questions that are very much top of mind for hospital executives. Yet the answers cannot be the same in every case, or sufficient healthcare coverage for an entire population could be affected. So understanding the cost of care is essential.